Differential diagnosis assignment for advanced pathophysiology. Patient scenario is a 28-year-old woman with opioid use disorder, uses IV heroin, has PTSD, no other medical problems or medications. Currently single, lives with several roommates, history of legal problems, sexually active with men and women, and consistent use of protection. The first differential diagnosis is infective endocarditis. Worserol et al. Note that people who inject drugs are at risk for infective endocarditis. Furthermore, the researchers note that between 2000 and 2013, a significant increase in the percentage of injection drug use, infective endocarditis, increased at the rate of 27.1% and 42%, all in the setting of the opioid crisis. Hinkle and Cheever describe infective endocarditis as a deformity or injury of the endocardium, which leads to accumulation of fibrin and platelets on the endocardium. The organism most associated with infective endocarditis among drug users is Staphylococcus, which invades those clots and endocardial lesions. The signs and symptoms are fever, chest pain, shortness of breath, and as part of the assessment, it would require 3 sets of blood cultures drawn from 3 different sites on the body at more than 2 hours apart, and an echocardiogram to assess for damage to the valves. Next differential diagnosis is bacterial pneumonia. Key risk factor for bacterial pneumonia is opioid preparations that promote respiratory depression, which causes shallow breathing pattern and predisposes to the pooling of bronchial secretions and potential development of pneumonia. Signs and symptoms include headache, low-grade fever, pleuritic chest pain, and shortness of breath while reclining, and the assessment would require a sputum gram stain and 2 blood cultures, as well as a chest x-ray. The final differential diagnosis is anxiety related to PTSD. PTSD can be defined as an anxiety disorder characterized by highly traumatic events that involved actual or threatened death or serious injury to self or others, to which the individual responded with intense fear, helplessness, or horror. That we may note that PTSD is at its core an anxiety disorder, and as such, anxiety is one of the primary nursing diagnoses for an individual suffering from PTSD. Halter and Varcolis note that an individual with anxiety may experience tension, pounding heart, increased pulse and respiratory rate, perspiration, and mild somatic symptoms such as gastric discomfort, headache, urinary urgency. In order to further assess if the patient is presenting with somatic symptoms in the setting of anxiety, the clinician would need to identify whether the patient is presenting with selective attention, whether the patient is struggling to think clearly, specifically by trying to assess whether the patient's problem-solving skills are operating at an appropriate level. In comparing to the first assignment, or first part of the assignment, only one of the 3 differential diagnoses are the same. While working as a CNA, I did work with patients, IV drug users, who had infective endocarditis, so I was thinking within that framework while doing the previous assignment. The bacterial pneumonia was nowhere on my radar. That only came after further research. And the PTSD, the psychiatric differential, seemed important to add to include and consider the patient's history of trauma.